Good morning and welcome to channel CSB333, where we'll be speaking with QUT student paramedics on the support of fluid therapy in pre-hospital care. For the body to maintain normal cellular function, fluid balance is essential. Intracellular fluid is within the cells, whereas extracellular fluid is outside the cells. Extracellular fluid is comprised of blood plasma and interstitial fluid, both having high concentrations of sodium and chloride. Acute care paramedics carry and administer the crystalloid solution sodium chloride 0.9%. We'll be focusing on this drug therapy. This is used to replenish electrolytes and maintain a stable balance when there is an undersupply of fluid. Fluid therapy is administered when there is an inadequate tissue perfusion, also known as shock. There are four major types of shock: cardiogenic, hypovolemic, disruptive, and obstructive, that mainly relate to one of four organ systems. Standall states hypovolemic shock relates to the blood and fluid compartments, while disruptive shock relates to the vascular system. Cardiogenic shock arises from primary cardiac dysfunction, and obstructive shock arises from a blockage of the circulation. As you can see, these major categories are then divided into subcategories. The Queensland Ambulance Service states that the perfusion is the ability of the cardiovascular system to supply the body tissues with an adequate blood supply to meet their function demands. To determine inadequate tissue perfusion, the patient's pulse, blood pressure, level of consciousness, and skin is assessed. The Queensland Ambulance Service states inadequate perfusion of an adult is skin, cool, pale and clammy, pulse below 50 beats per minute or above 120 beats per minute, blood pressure 60 to 80 systolic, and consciousness either alert or altered in their orientation to time and place. Whereas a child's inadequate perfusion is skin, cool, pale and clammy, pulse below 75 beats per minute or above 120 beats per minute, blood pressure 40 to 50 systolic, and consciousness alert and interacting normally for their age. If two or more are diminished, then the patient has inadequate tissue perfusion and will need the fluid therapy to maintain normal cellular function. Today we'll be covering the topics of dehydration, burns, sepsis, trauma in relation to the support of fluid therapy in pre-hospital care. Firstly, Naj is going to speak about dehydration. So what is it? Who is affected? And what are the signs and symptoms?
Hi, I'm Naj, and today I'm going to talk to you about dehydration. Dehydration is a potentially detrimental condition which has a patient experiencing excessive fluid loss. Usually the elderly and children are affected due to the physiology of their bodies. Today I'd like to focus on gastroenteritis in children. So signs and symptoms of dehydration as a paramedic we should be looking for in adults include hypotension, syncope, thirst, muscle weakness, dysuria, and oliguria. In children, they can range from dry diapers, high fever, dry mouth, crying with no tears, and dry or sticky tongue. The treatment for dehydration for paramedics, we target it at the symptoms that the patient is presenting with. So the Queensland Ambulance Service practice guidelines for hypothermia, hypothermia, and nausea and vomiting outline the treatment options for these conditions include fluid therapy, provision of antiemetic and or analgesic drugs, and temperature monitoring. So what's research telling us about gastroenteritis and dehydration in children? Research has indicated for children with gastroenteritis experiencing dehydration, it's best to use 0.9% sodium chloride fluid. In 2010, the Journal of International Pediatric Nephrology Association published a paper regarding the improvement of intravenous fluid therapy for children with gastroenteritis. Researchers questioned the safety of administering 0.9% sodium chloride followed by a hypertonic solution ranging from 0.2 to 0.45% sodium chloride. They determined 0.9 was best for volume depletion, prevention of dysnatremia, but not without risks, as they also acknowledged that electrolytes should be constantly monitored. Similarly, the QAS released a drug therapy protocol for 0.9% sodium chloride fluid, stating that in instances of inadequate tissue perfusion, it was appropriate to administer the fluid. They also pointed out that caution should be taken when administering fluids, as excessive administration could lead to fluid overload, and pediatric patients should be reassessed after every 10 mils per kilogram fluid administration. In 1985, the Department of Pediatrics in Barami Children's Hospital published a randomized control trial comparing oral and intravenous rehydration therapy in children with gastroenteritis. Rehydration interventions were done in 2 phases, the rehydration and the maintenance phase. They determined that oral rehydration was superior, with children experiencing severe diarrhea and dehydration was adequately treated in these children. In contrast, the Cochrane Library published a review in 2006 reviewing 17 randomized control trials and discussed and compared oral and intravenous rehydration. They concluded, with the evidence of the trials, that there was no clinically important differences between both routes of administration. Thank you.
Amy is now going to talk about sepsis.
So what is sepsis? Sepsis is a major cause of death worldwide and requires urgent intervention by a healthcare professional. It is a complex disease state that can affect a diverse group of people in their pre-hospital setting and requires early recognition based on vital sign abnormalities and clinical features. Sepsis can cause organ dysfunction as a result of the body's inflammatory response to most commonly a bacterial infection, but it can also be caused by a viral infection, fungi, or a parasite. This presents with circulatory, cellular, and metabolic abnormalities. The physiological response to sepsis will result in widespread peripheral vasodilation, increased capillary permeability, complex coagulopathy, and depressed myocardial function. This can be clinically shown by tachypnea, hypotension, tachycardia, hypoxia, skin changes, deteriorating GCS, and oliguria. It is also stated in the Sepsis Clinical Practice Guideline for QAS that sepsis should be considered for any deteriorating patient. What is the treatment in place? The first-line treatment of low to high-risk sepsis patients in the pre-hospital phase is aggressive fluid therapy with normal saline 0.9%. The minimum rate for intravenous fluid administration is 20 mils per kilogram, but 60 mils per kilogram has been given depending on the length of the pre-hospital phase. This increased intravascular volume will increase the cardiac output for the patient. The initial indication of improvement from the fluid therapy will be reflected by the blood pressure improvement, decreased heart rate, improvement in the skin perfusion, and stabilization of the GCS. What does the evidence say? A systematic review published by the Emergency Medical Journal in 2016 has identified that reducing time to achieve adequate blood pressure using intravenous fluid reduces risk of death. This is then further supported by evidence stating that the timing of the initial fluid therapy correlates to the responsiveness of this treatment, and furthermore, the patient's hemodynamic response should then determine the following treatment of fluid therapy. There is an impression to suggest that if a patient is not hemodynamically compromised, there is no indication to administer intravenous fluids, and that the reduction of mortality is only limited to the patients who are hemodynamically compromised with a low systolic blood pressure. And although this study has limited evidence to support this, it does follow the statements above.
Harley is now going to talk about burns.
Core to the treatment of burns is the administration of fluid, ultimately to prevent shock, dehydration, and ischemia, which can lead to catastrophic outcomes for patients. After a burn, particularly those that penetrate the epidermis into the deeper layers of the skin or tissues, there's a release of inflammatory mediators as part of the immune response. Ray et al. In 2016 highlight that this inflammatory response increases vasodilation and vascular permeability, allowing fluids to shift into interstitial spaces and therefore decreasing the effective circulating volume, creating a state of profound hypervolemia. This hypervolemia is responsible for 38% of burn deaths, with multi-organ failure or sepsis accounting for a further 28% of deaths as a result of thermal injury. Nielsen et al. In 2017 highlight that this fluid shift occurs most significantly in the first 24 hours of a burn injury, and therefore rapid fluid resuscitation is key to prevent ischemia, dehydration, shock, and death. QAS, as outlined in the CPM, use the 15B formula for severe burns. This being that the milliliters per hour that's to be infused for the first 24 hours is equal to the total burned surface area of a person, rounded to the nearest 10% and multiplied by 15. Additionally, 200 milliliters of fluid should be added per hour if the patient is over 100 kilograms in weight. Therefore, for a patient that weighs 70 kilograms with burns to 30% of the body, they should receive 450 milliliters of fluid per hour for the first 24 hours. One core advantage of the 15B formula is that it helps negate difficulty in estimating total burn surface area, which can occur in other fluid formula for major burns, such as the Parkland formula, as it calls for rounding to the nearest 10%. QAS also indicates fluid therapy in burns, aside from in a shocked patient, if the burn total body surface area is 20% or greater in adults. Tricklebank in 2009 highlights that number varies significantly from location to location and between hospital and pre-hospital contexts. In some areas, such as in the UK, commencing fluid resuscitation at an estimated 15% of total burn surface area is appropriate. Ultimately, fluid resuscitation is of utmost importance in burns patients, particularly in the immediate period following the injury.
Sally is now going to talk about trauma.
The hemorrhagic shock is defined as a state of hypoperfusion due to significant rapid blood loss. The major cause is acute hemorrhage secondary to trauma, but there are other common causes, including GI bleeding, coagulopathies, complications of pregnancy, and other reasons. Without support, major blood loss can lead to hemodynamic instability and organ hypoperfusion and eventually death. So is fluid therapy indicated in the pre-hospital environment? So obviously stopping the bleeding is the primary goal of management. However, also important is to restore and maintain intravascular volume. And this can be done via volume resuscitation. So according to Dynamed, which is a cutting-edge clinical decision support tool, recommendations are to begin with an isotonic crystalloid such as normal saline in hypertensive patients. If there is no brain injury, replace volume to maintain BP at 80 to 90 until bleeding can be stopped. If there is severe traumatic brain injury, replace to maintain mean arterial pressure of at least 80. If the blood loss is more significant or the patient is unresponsive to crystalloid, then a blood transfusion would need to be considered. The QAS has developed a range of clinical practice guidelines around this topic. So firstly, the one on hemorrhagic shock and trauma, really in terms of IV fluid replacement, that's dependent upon whether there is an associated traumatic brain injury or not. Also, the CPG for hemorrhage control recommends 250 to 500 ml boluses of sodium chloride. The Resus Traumatic Guideline recommends red blood cells or sodium chloride administration to restore circulating blood volume. If we look back at the research, how does saline support this? One of the first studies was undertaken by Bickel and others in 1994, and there was another study by Sampoulos undertaken in 1997. So these were both prospective studies that demonstrated an increased survival when a low and delayed fluid volume resuscitation was used for trauma patients. More recently, a pilot randomised control trial demonstrated a 24-hour survival benefit in hypertensive patients when they were treated with volume replacement. It is now widely accepted that during the initial phase of hemorrhagic trauma shock that a restrictive volume strategy is used in the hypertensive bleeding patient to achieve target BP until bleeding can be controlled, supported with isotonic crystalloid solutions. There are a number of limitations, however. We know that sodium chloride is an effective volume expander. It's cheap, it's easy to use, but it may increase edema. It also needs to be used with caution in patients with acute or heart failure or history of heart failure, renal failure, or uncontrolled hemorrhage if there's no severe head injury. There's also risk of acidosis and kidney injury for resuscitation greater than 1.5 litres.
As you have just seen, fluid therapy is vital for pre-hospital care to allow patients a better outcome. Fluid therapy is administered when there is inadequate tissue perfusion, it replenishes electrolytes, and maintains a stable balance when there is undersupply of fluid within the body. For more on this report or further investigations on the topic, here is a list of peer-reviewed resources used.